Next, we have use of anti-VEGF agents in cataract surgery, choice and timings. Dr. Srinivas Joshi, he is a member of All India Ophthalmic Society ARC South Zone, and he's a trained vitreoretinal surgeon and expertise in adult and pediatric retinal pathology, and he has been in an internationally recognized for his contributions. Over to you, sir.
Thank you, Dr. Rajesh, for including me in this IC. Thank you, entire office bearers of KSOS, for hosting a wonderful function. So I'll be talking on the uses of anti-VEGFs in the cataract surgery. So we all know that 7.5 million cataract surgeries are done annually. So why do we need to know about this? Because of the coexisting retinal pathologies, whether it's a diabetic macular edema, AMD, PDR with TRD, or retinal vein occlusions. So what happens if we do the cataract surgery without giving anti-VEGFs in a case of PDR with TRD? They usually progress more. The tractional retinal detachment sometimes will progress more. Retinal vein occlusions, pre-existing macular edema will exacerbate. Intensify the AMD activity. This is not actually proven. There is still a debate over it, but we'll think over it that, okay, it can accelerate the progression of dry AMD to wet AMD. And of course, diabetic macular edema is already established that the cataract surgery progresses the diabetic macular edema. So why do we need anti-VEGFs? In all these four conditions, again, what is the only one Ramabana what we can say is anti-VEGF, as it's a crucial adjunct in the cataract surgery to minimize the intraoperative complication and also to maximize the visual outcome. So what is the mechanism of action? I think we all know about it. I'll not go into the detail, but most of these are receptor blockade. You know, what of bevacizumab, ranizumab, VEGF trap, faricimab, all these, they block extracellularly. The rest what they are planning is intracellularly. Of course, they have not come into the market, but good to know that there are tyrosine kinase signaling blockade which prevents the angiogenesis to happen. So these are the various anti-VEGFs available in the market today. And what are the choice of the anti-VEGFs? Yes, that's very important. Avastin, yes, definitely 70% of the country still uses. The only thing is it's off-label drug. Ranibizumab is still the gold standard. Aflibercept Eylea is definitely a better injection, but patient should have some good paying capacity. And brolucizumab Peginax is like a bomb. It's a very good activator because it has around 11 to 12 proteins per molecules per vial. So that itself shows that it is a very strong drug, but of course it has its own side effects. And faricimab, Vabysmo, which has now come, these are the longer acting anti-VEGF agents. So if you look into the efficacy, all approved agents show similar efficacy almost. I'm not going into the head-to-head trial. Cost and availability, bevacizumab is lower dosing, and if the patient is less affordable, then you can give frequent monthly injections, or if they are affordable, you can go for the longer acting injections. What are the timing of the anti-VEGFs? That is very, very important. Preoperatively, in case of PDR with TRD, we usually give at least 1 week prior to the surgery. So that minimizes the bleeding intraoperatively. And of course, intraoperatively, if you have not planned vitrectomy, there is a macular edema, then you can plan both diabetic cataract surgery along with the anti-VEGF injection. The only thing is, if you are planning with Peginax or brolucizumab, then we don't combine both together because brolucizumab is known to incite the inflammation. So we don't combine that. But rest of the injection can be given, including Ozurdex implant can be given along with the cataract surgery. Advantage, the patient come one, both the things can be done at the same time, and then patient can go back rather than get an injection. But there are other theories which they say that first try to minimize the diabetic macular edema and then go in for the cataract surgery. Both can be done. So now looking preoperatively in case of PDR, now you can see here what happens if you leave late. The patient receives injection and he doesn't turn up or comes after a month. So this is the problem happens, what is called as a crunch syndrome, which is very dangerous. If the patient vision drops down, it's very difficult to get it back. So we have to be very careful. I'll just show a few of the videos where we used anti-VEGFs, we did not use anti-VEGF. So here you can see the anti-VEGF was used. Now, of course, I'm using a different filters in the Ingenuity. That is the, I don't want to speak more on that. But what is important here is, see here, the PDR, I'm cutting the membranes, I'm using a green channel of the Ingenuity. There is minimal bleed at all. You can see that helps the vitreoretinal surgeon to dissect these membranes easier and get rid of these membranes more better, so that you have less iatrogenic breaks. Lesser the iatrogenic break, This is the post-op picture of the same patient. Now let's look into another case where anti-VEGF agent was given, but given only in the form of 3 days. So what happens here? Do you see cycling through the different custom filters? Now I'm using again, I'm not going to talk on the filters, but here you can see here, it is a bloody red situation. So that's why I had to change the filters here so that the blood get masked, the red color get masked, so that I can peel these membranes pretty much easier. Now you see here, I'm just, kind of fluoresce. The fluorescence kind of things gets activated with these membranes. But when I come to the normal mode, see here, this is how the blood keeps happening. So the prodigious use of anti-VEGF before the surgery is very, very important for the vitreoretinal surgeons. Now coming to the next, this is the diabetic macular edema, where I used anti-VEGF before and then went ahead for the cataract surgery. So what happens in these cases where there is a very thin ILM, then while peeling the ILM, the de-roofing can happen. So subside the diabetic macular edema or the cystoid macular edema and then go in for the vitreoretinal surgery. So again, we're doing a cataract with vitreoretinal surgery. So what I do in these kind of cases, I always tell my anterior segment surgeon, first do the cataract surgery, give an anti-VEGF injection. I will take care of the retinal part after a week. Two-stage procedure, why important? Intraoperative meiosis, again a problem while doing a vitreoretinal surgery if you're climbing it on the same stage. And second thing is, you give some time for the anti-VEGF because we need anti-VEGF to work. So at least 8 to 10 days time is given. So by that time, post-cataract surgery, you will have a stable chamber. When I'm indenting, I don't want any of these ports to open up and the iris keeps coming out through that port. So these are the several various advantages of using the anti-VEGFs along with the cataract surgery and plan the vitreoretinal surgery later. So this is the same case which I want to show here. See here, this is a small drape of ILM. Now you see there's completely the post-operative along with the anti-VEGF agent. So phaco, yes, phaco does increase, does not increase the ERM progression. And this is the case of DME. As I was talking about here, what we did was, did the cataract surgery and the anti-VEGF agents both together, or you can give anti-VEGF agents before and then plan the cataract surgery. Either of thing can be done. But only in case of, if there is, say for example, the PDR, in these cases the laser has to be done, anti-VEGF has to be given and then plan for the cataract surgery. Otherwise the bleeding chances might increase. That is very, very important. So caution has to be exercised because the reports have shown that multiple use of anti-VEGFs also causes risk of retained lens fragment, probably because of the lens touch, which happens because of the, and endophthalmitis rates have also increased is what these publications say. So to summarize, I think judicious use of anti-VEGF important, collaboration that is between the cataract and retina specialist is of paramount importance. Thank you very much for the patient listening. Thank you for the opportunity.